Good morning, everyone. Today we are going to talk about the cancer of base of tongue. My name is Chen Ki-ying Janice. Our patient is a male who is 75 years old. He is an ex-smoker and ex-drinker. He suffered from CA base of tongue and lateral hypophyresis. He also had dysphagia recently. The base of tongue is the posterior one-third of the tongue, which is also part of the oropharynx, including the tonsil, pharyngeal wall, and soft palate. The common risk factors are tobacco smoking and heavy alcohol use, which is also correspond to the past habits of the patient. The epidermal growth factor receptor is commonly found on the surface of cancer cells, which can promote the growth and proliferation of the cancer. Dysphagia and feeling a lump in the throat is the most common sign and symptoms in BOT cancer. If you feel a lump in the neck, the cancer cell may have already spread to the cervical lymph node. The patient has suffered from CA larynx in 2001 and CA left hypopharynx in 2011. In the December of 2011, he was diagnosed with BOT cancer.
I'm Hongwei Silva. For patient investigation, tissue biopsy showed malignant cells. Also, PET scan for patient was performed. The report shows a remarkable FDG uptake at the central part of the base of the tongue, which identified tumor of 22 times 13 millimeters in size. It extended to the right side of the tongue and right lateral oropharyngeal wall. It was classified as T2 in tumor staging. A small FDG uptake by lymph node identified in level 2 right jugular chain, while the lymph node extension was not identified in the report. For the remaining lymph node and regions, there is no significant FDG uptake. We suggest that the stage of the cancer is T2 with lymphatic spread and no distant metastasis.
I'm Chen Ki-ying. The general investigation are neck palpation, laryngoscopy, barium swallow, biopsy, etc. The BOT tumor commonly spread laterally and inferiorly to the larynx, hypopharynx, and preepiglottis space. These are the commonly infolded lymph nodes. BOT cancer also have high tendency to spread to the cervical nodes. Therefore, bilateral neck irradiation is required. These are the staging system TNM.
I'm Silver. The patient was treated with concurrent cetuximab and tomotherapy. Tomotherapy can deliver beams continuously from all angles around the patient to achieve a more precise tumor dose. Also, it can provide daily 3D image of the tumor by its integrated image guidance system. The energy used is 6 mV. There are 3 dose prescriptions due to the use of simultaneous integrated boost technique. The dose prescriptions of GTV of tumor is 2 gray per fraction, while the GTV of involved lymph node region is 1.83 gray per fraction. The PTV was prescribed by 60 gray in 35 fractions. Here is the setup details of the treatment. The advantage of simultaneous integrated boost is that it can apply different prescriptions to more than one area in one session. Therefore, the gross disease at the primary disease site can receive high dose per fraction, while maintaining low dose to elective areas. It gives a more precise and accurate dose distribution. This is a similar case treated with SIB technique. We can see that there are 3 CTV was contoured based on the risk definitions of microscopic spread, and the 3 different dose prescription was given. The tumor was located at a compact region of the head and neck. There are many critical organs nearby, for example, the spinal cord, parotid, and brainstem. Since the patient had received previous radiation treatment to the larynx, the dose constraints of the organ at risk will be limited and smaller than normal dose constraint, particularly the spinal cord and brainstem.
I'm Chen Ki-ying. For the concurrent target therapy, cetuximab, also named Erbitux, is an anti-cancer target therapy for head and neck cancer. to inhibit the epidermal growth factor and stop the proliferation of tumor cells. As the prescriptions are not stated in the treatment record, I find a recommend prescription when used with radiation therapy. It can be injected intravenously 1 week before the RT and continue for 6 to 7 weeks. Using cetuximab with RT are proven to have better local control and survival, according to the research of New England Journal of Medicine. The possible side effects are xerostomia, osteoradionecrosis, adenophagia, etc. However, the advanced side effects are less common nowadays. Most patients only experience mild and temporary side effects that may include nausea, fatigue, and skin irritation.
Silver, for the patient follow-up after complete of treatment, it is suggested continuous endoscopic examination and image study to see whether it has residual or recurrence of the tumor. The interval of each follow-up can be gradually increased with time.
I'm Chen Ying. The general treatment management includes radiation therapy and chemotherapy. As BOT cancer has high tendency to spread to bilateral cervical node, bilateral neck irradiation is required. Other treatment modalities can include surgery, radiation therapy, and chemotherapy. Surgery is not recommended for BOT cancer as it is responsible for swallowing. Removal may affect the quality of life. If surgery is conducted, reconstruction surgery may be required. For the radiation therapy, we will discuss these 6 techniques. For the conventional RT, it will use lateral opposing field to irradiate the primary tumor and pus margin of retropharyngeal lymph node to achieve local tumor control. After 45 gray, the spinal cord are blocked. For the anterior neck field, it aims at irradiate the cervical lymph node to eliminate the tumor cells and also prevent bilateral spread. It is important to shield the spinal cord and lung apex. For the IMRT and VMAT, they use multileaf colorimeter to modulate the intensity of radiation beam during beam on with different beam angles. This study compared the dynamic MLC IMRT and VMAT plans for 13 base of tongue cases. Both plans have good target coverage and normal tissue sparing. However, we may give good quality of the plan as IMRT with less delivery time and improved efficiency. The conventional RT is a simple technique which has less organ sparing. The IMRT technique can have conformal dose to target with sparing of normal tissue. And the tomotherapy is highly conformal, and it can good sparing of normal tissue with image guide function. Tomotherapy has the shortest treatment delivery time. Therefore, it can provide highest efficiency and better treatment outcome on tumor conformity and OAR sparing. It is recommended to the patient. A study compared helical tomotherapy and VMAT for 166 head and neck cancer patients. Tomotherapy provides better local regional control and cancer-specific survival with fewer salivary disorder.
Silver, proton therapy can be an option for radiation therapy. It uses proton rather than X-ray to treat cancer. It has a low linear energy transfer when they enter the body, but give up a lot of energy at the end of their track, which is called the Bragg peak. So maximum dose given to tumor, while less dose delivered to normal tissue. Another advantage of proton therapy is the rapid dose fall-off after Bragg peak. It gives a minimal exit dose. The characteristic of Bragg peak and rapid dose fall-off of proton therapy precisely arm the highest dose at the tumor and avoid healthy tissue. Here is the similar base of tongue cancer treated with proton therapy. It shows that proton has the ability to control the tissue penetration and eliminate full beam lines. Therefore, it has better OAR sparing, such as spinal cord, brainstem, oral cavity, and salivary glands, and possible side effects may be minimized. Compared to tomotherapy, After a shorter build-up distance to Dmax, the radiation decreased gradually and lead to more normal tissue received radiation. Therefore, we suggest the proton therapy for the patient in our case with tumor located centrally and in the highly compressed region near critical organs. Since proton therapy is a relatively new technique which first adopted in Hong Kong in recent years, it may not be available for patients in that year. Another possible option is brachytherapy. It is performed by interstitial brachytherapy implant of Iridium-192 using afterloading technique. It has the advantage of functional organ preservation and provides specific intensive local radiation to the base of tongue. Brachytherapy has the advantage of a more rapid fall-off in dose, so better sparing of organ at risk. However, brachytherapy is a relatively more invasive treatment to the patient because it requires insertion of site-specific application under sedation or anesthesia. Therefore, brachytherapy may not be suggested for the patient in our case who is old in age.
I'm Chen Ying. For the prescription in LT alone situation, 2-grade perfection is given to total 70 grade and stop. In external beam LT and brachytherapy situation, LT is performed first to total 50 grade, then 3-grade perfection is given to total 30 grade for brachytherapy. For the chemotherapy, it is usually combined with radiation therapy for increased survival probability and better prognosis. Therefore, it is recommended to combine chemotherapy with radiation therapy. The most common used drug is cisplatin and 5-FU. The prognosis of BOT cancers are much better in using radiation therapy than surgery. And this is the end of our presentation. Thank you.